Good day. Our topic for today are the drugs for seizure disorders. Now, for the introduction, the term epilepsy refers to a group of chronic neurologic disorders characterized by recurrent seizures brought on by excessive excitability of neurons in the brain. Seizure is a general term that applies to all types of epileptic events, while convulsion has a more limited meaning, applying only to abnormal motor phenomena, for example, the jerking movements that occur during a tonic-clonic attack. Now, seizures are initiated by synchronous high-frequency discharge from a group of hyperexcitable neurons called a focus. So a focus may result from several causes, including congenital defects, hypoxia at birth, head trauma, brain infections, stroke, cancer, and genetic disorders. Seizures occur when discharge from a focus spreads to other brain areas, thereby recruiting normal neurons to discharge abnormally. We have here the new classification of seizure types. We have the focal onset aware seizures. Focal onset aware seizures occur when a person is awake and aware during a seizure. This used to be called a simple partial seizure. We also have a focal onset impaired awareness. When a person is confused or their awareness is affected in some way during a focal seizure. This used to be called a complex partial seizure. The focal onset can be non-motor and non-motor, ranging to focal to bilateral tonic-clonic. Next will be the generalized onset seizure. These seizures affect both sides of the brain or group of cells on both sides of the brain at the same time. This term was used before and still includes seizures like tonic-clonic, absence, or atonic. So generalized onset have impaired awareness and can be both motor or non-motor. Then we have the unknown onset seizures. So when the beginning of a seizure is not known, it's now called an unknown onset seizure. It can be either be tonic and non-motor unknown onset seizures. Now, the AEDs or the anti-epileptic drugs can be grouped into two major categories. We have the traditional and the newer anti-epileptic drugs. So the traditional group has 7 major members. The group of newer anti-epileptic drug has 15 members. So in this table, we're going to compare the two. So for the efficacy, the traditional AEDs are well established, while the newer AED have equally good but less well established. Traditional AED have extensive clinical experience with well-established therapeutic niche. The tolerability in newer AED is better tolerated compared to your traditional AED. For the pharmacokinetics, they are often complex in traditional and extensive drug interaction compared to your newer AED. And in safety and pregnancy, the newer AED are more safer than your traditional AED. But newer AED are more expensive compared to your traditional anti-epileptic drugs. Now, the traditional anti-epileptic drugs has been used in for decades. And the prototype of these drugs for epilepsy is your phenytoin, which is the traditional agents. For the newer agents, we have the oxcarbazepine. So first, let's discuss the prototype for the traditional anti-epileptic drug, your phenytoin. So phenytoin is a prototype for traditional anti-epileptic drugs. It is the most widely used anti-epileptic drugs. For the mechanism of action, at the concentrations achieved clinically, phenytoin can cause selective inhibition of sodium channels. It slows the recovery of sodium channels from the inactive state back to the active state. So as a result, the blockade of sodium entry is limited to neurons that are hyperactive. So the drug suppresses the activity of seizure-generating neurons while leaving the healthy neurons unaffected. And now for the pharmacokinetics of phenytoin. So for the absorption or the suspension and chewable tablets is relatively fast. The extended release capsule absorption is delayed and prolonged. For the metabolism, the capacity of the liver to metabolize phenytoin is very limited. So doses of phenytoin needed to produce therapeutic effects are only slightly smaller than the doses needed to saturate the hepatic enzymes. So consequently, if phenytoin is administered in doses only slightly greater than those needed for therapeutic effects, the liver's capacity to metabolize the drug will be overwhelmed, causing the plasma levels of phenytoin to rise dramatically. Because of saturation kinetics, the half-life of phenytoin varies with the dosage. So now, for the adverse effects of phenytoin. First, we have here the effects on the CNS. So, at therapeutic levels, sedation and other CNS effects are mild. So at plasma levels above the toxicity level, nixtammus is relatively common and include sedation, ataxia, diplopia, and cognitive impairment. They also have gingival hyperplasia. So gingival hyperplasia is characterized by swelling, tenderness, and bleeding of the gums. Then we also have dermatologic effects. So between 2% and 5% of patients develop a morbilliform measles-like rash in patients who take phenytoin, which may progress to more severe reactions such as your Stevens-Johnson syndrome or your toxic epidermal necrolysis or your TEN. Then we also have effects in pregnancy. So phenytoin is a teratogen. So it may cause cleft palate, heart malformation, and your fetal Huntington syndrome. Phenytoin also has cardiovascular effects. So when phenytoin is administered by IV injection, cardiac dysrhythmias and hypotension may result. Now for the phenytoin preparation dosage and administration. Now the preparation for your phenytoin can be in tablet or a suspension or extended release capsule. The dosage is highly individualized. For adult, the typical dosage is 100 to 125 mg 3 times a day, with a maintenance dose of 300 and 600 mg per day. While in children, the initial dose is 2.5 mg per kilogram twice a day, with a maintenance dose of 4 and 8 mg per kilogram per day. So the dosing objective is to produce levels between 10 and 20 microgram per ml. So when treatment is discontinued, the dosage should be reduced gradually since abrupt withdrawal may precipitate seizures. Another anti-epileptic drug is your valproic acid with a trade name Depakine. It is an important anti-epileptic drug used widely to treat all major seizure types. So valproic acid mechanism of action appears to act by three mechanisms. First is your suppression of high-frequency neuronal firing through blockade of sodium channels. Second, it suppresses calcium influx through T-type calcium channels. And third, it may augment the inhibitory influence of your GABA. And now for the adverse effects of your valproic acid. We have the gastrointestinal effects. So nausea, vomiting, and indigestion are common but transient effects of your valproic acid. It is also a hepatotoxic. So rarely, valproic acid has been associated with fatal liver failure. Also, it's associated with pancreatitis, which is a life-threatening, which may develop in children and in adults. And also, valproic acid is highly teratogenic, especially when taken during the first trimester. Neural tube defects, such as spina bifida, are of the greatest concern. And it can also cause hyperammonemia if given with topiramate. It may occur with or without encephalopathy. Next drug will be your phenobarbital. So phenobarbital, one of the oldest antiepileptic drugs, is effective and inexpensive, and it can be administered just once a day. So for the mechanism of action, phenobarbital suppresses seizure by potentiating the effects of your GABA. So it binds to GABA receptors, causing the receptors to respond more intensely to GABA itself. For its therapeutic uses, it is used for your epilepsy. So it is effective against partial seizures and generalized tonic-clonic seizures, but not the absent seizures. It is also used for your sedation and induction of sleep. Like other barbiturates, phenobarbital can be used for sedation and to promote sleep at night. Now for the adverse effects of your phenobarbital. First is your neuropsychologic effects. So drowsiness is the most common CNS effect. Depression may occur in adults, and older adults may experience agitation and confusion. Like any other barbiturates, phenobarbital can cause physical dependence. Also, it can exacerbate your intermittent porphyria. So barbiturates and phenobarbital are absolutely contraindicated for patients with a history of this disorder. And it should be used in caution in pregnancy. The use of phenobarbital during pregnancy poses a significant risk of major fetal malformations. So here are the list of your antiepileptic drugs and their pharmacokinetics. So we have the carbamazepine, which has a variable half-life. The metabolism is by CYP3A4. It induces hepatic drug metabolism. We also have etoxosimide. The peak is around 1 to 7 hours. We also have phenobarbital with a metabolism by CYP279, which is the primary metabolism. We also have phenytoin with a long range of half-life of 7 to 42 hours. Then we also have fosphenytoin after being converted to phenytoin has a half-life of 15 minutes. We also have primidone with a metabolism via hepatic oxidation. We also have valproic acid with a half-life of 9 to 19 hours. And the metabolism is via hepatic. We also have esclarcarbazepine, ezogabine, felbamate, and gabapentin. For continuation, for your antiepileptic drugs, we have lacosamide with a half-life of 13 hours. We also have lamotrigine with 25 to 23 hours as monotherapy half-life. The levetiracetam metabolism is by hydrolysis by enzyme in the blood. We also have oscarbazepine with the hepatic cytosolic enzymes MHD at its metabolism. For the perampanel, the primary excretion is through the feces. Then for the pregabalin, the peak is 1.5 hours and the food delays by 1.5 hour. We also have rufinamide. The metabolism is by carboxylesterase mediated hydrolysis. We have your tiagabine with major metabolism is by CYP3A4. Then we have topiramate with half-life of 12 to 13 hours for children and in adults 19 to 23 hours. The metabolism is minimal via hydroxylation, hydrolysis, and glucuronidation. We also have the gabapentin. The peak is 1 hour. The food delays by 1 hour. We have zonisamide with a long half-life of 63 hours. And that's it for your anti-epileptic drugs. Thank you for listening.